Good afternoon, everybody. A great time to be with you again. My name is EMMANUEL EDAFE. I work in the University of Port Harcourt and also teachers in the University of Port Harcourt Department of Medicine. So we will talk about, in the next 20 minutes, we will just briefly talk about electrical storm. This one, the center one, okay. So there is nothing that I need to 15 minutes, okay. So by the way, electrical storm it refers to multiple occurrences of readings that can easily kill the patient. And these readings include ventricular tachycardias, ventricular fibrillations. These are the major readings. So anybody that has that that has almost 3 in 24 hours, you refer to that person as having electrical storm. I won't bother you with this because you will have the slide. But let me just quickly go to the cases. This is case 1. Now, case 1 refers to a woman with biventricular failure who had a reduced ejection fraction. He had a CROT implanted 2023, and she presented to a hospital nearby, and the presentation was that as if she's fainting, she just closed her eye and jerk, and she will receive a shock, boom, and she will return back. So the first thing that she was told was that your device is not working. So that is not the way to make a diagnosis of device not working. So she had that over 24 hours in that hospital, and as at the time they now call us, that was the following day, she has had almost 15 of that episode. And when she now came, you can see what we printed out as what? You can see that reading on both sides. What do you call that reading? Ventricular what? Fibrillation. So that was what the lady was having. So at the end, let me just summarize this case. At the end, the lady had 148 shocks as at the time she stayed with us, and she survived it before she departed at home. So this is a native reading. No, not dead. Departed home means that she was discharged to her house. Okay. So case 2 is a 56-year-old lady living with type 2 diabetes for about 10 years and hypertension for about 3 years. She presented with sudden onset of breathlessness, chest pain, then the blood pressure, was recorded at emergency, and this was what we saw. What do you call this reading? This is ventricular what? Tachycardias. This is ventricular tachycardia. You call this is monomorphic ventricular tachycardias. And you can see it is monomorphic ventricular tachycardia. So this was, we planted a device, and during the device, we shocked this patient for about 8 times, I think so. This happened in cardio care here. And you can see where the shock comes and where it goes into sinus reading. So this was the device that was implanted for the patient. 8 shocks, yes, correct. So then this is another case. Let me just move to the second one. It's the same patient. So okay, it's the same patient. So the patient 3 was 2019. She had a St. Jude ICD implanted outside Nigeria, and she returned home to Owerri. And around 8 p.m., I was called that she kept having shock from the device, and we gave all the medication because I was not in Owerri. The issue was the following morning, she will now be moved to where I was in Port Harcourt. But unfortunately, she had about 35 shock from the device, and the device ran down. Despite all the medication they gave, the lady passed on around 2:30 a.m. in the morning of that very night. So The third case was also an electrical storm. This was 2018. A 76-year-old male who was living with type 2 diabetes, dyslipidemia. She had STEMI who presented with ventricular. The presentation of the STEMI was ventricular tachycardia. That was just the presentation of the STEMI. And we stented it. After we stented, the man refused an ICD, so she lived with that stent for 1 year, and she had another episode of electrical storm again. It was there that we deployed an ICD for this patient. Now, the fifth one happened in Uyo. I was called. This patient was a young male, I think of 26. He was admitted to the hospital with pulseless ventricular tachycardia. And do you know the story was that there was no functional defibrillator. So they resorted into medication. You know, medication has a very high rate of failure when you get to this kind of busier rhythms. So the patient didn't survive it, and he passed on. So these are the issues. So from whatever hospital you come from, you have to make every effort to make sure that this group of people are properly served by having the basic skills to serve them. And among the basic skills is what you came here to learn today. One of them that is key and most important is what? Basic and advanced life support. Okay? So now let's look at the discussion. If you look at this, you will notice very well that there are several definitions over the years that explain what electrical storm is. But if you look at what the guideline is now, a patient that has a ventricular arrhythmia that is in form of ventricular tachycardia or ventricular fibrillation 3 times in 24 hours, that patient qualifies for electrical storm. Or a patient who has inappropriate shock from an ICD that is implanted and had that for 3 times in 24 hours, that patient also qualifies for this issue of electrical storm. Let me not disturb you with all these incidents because my time is really very short. You will have the slides. Where I want to go to is how do you classify this electrical storm? You can classify them as monomorphic ventricular tachycardia, polymorphic, or ventricular fibrillation, or those who have ICD with inappropriate shock from the event. Okay, monomorphic ventricular tachycardia, I don't want to dwell on, you have been talking about all this. Yeah, this is polymorphic ventricular tachycardia, which is we also call torsade de pointes. This is torsade de pointes because it's twisting around the clock. Okay, this is ventricular fibrillation. Now, when you come to this ladder reading, they are very important in your advanced life support. The ones that are most important to us are the shockable and the not shockable reading. Now, the ladder readings, 2 of them are not shockable, are what? Asystole and what? And pulseless electrical activity. For asystole and pulseless electrical activity, the basic thing that you do there, CPR, probably with epinephrine. Then when you come to the shockable rhythms are the ventricular, pulseless ventricular tachycardia and ventricular fibrillation. These are shockable rhythms. So they are important that you have your AED or you have your manual defibrillator so that you'll be able to take care of them. So CPR plus shock plus the medication serve that purpose out for you. Okay, I've described all this. So this, what do you describe this? How do you call this? This is ventricular. What rhythm is this? You have been hearing this is yesterday. This is ventricular what? Fibrillation. This is ventricular fibrillation. If you call it another, I don't know. Yeah, that is what is there. So this is also what you call this one. This is what? Ventricular what?
It be like jaga jaga now. The one
So
that we
this-
say is like jaga jaga. What is
Yes.
that one? Well, ventricular word. The one that says like jaga jaga, that you check that you check that the thing is connected.
Yep.
Fibrillation. I mean ventricular fibrillation.
Yeah. So I was sitting at the back eating when the other consultant was Dr. Taiwo was talking about all these risk factors. So there's no need of repeating them over and over again. So the clinical presentations we have talked about it, but the key thing that you should remember is this. When you are talking about electrical storm, most of them are as a result of ventricular fibrillation and pulseless ventricular tachycardia. Monomorphic ventricular tachycardia is also a very significant number in this group that you talk about. Okay, so I'm just trying to screen down to the treatment. Now, in our environment, how do we treat it? Now, the question is that when you meet a patient on emergency, the first thing that you should do, I'm sure you have been told, and if it is in hospital, the protocol is a little bit different than outside hospital. If it is in hospital, you just signal your team because you know that the hospital environment where you are is safe most time. So you signal your team, start CPR, get a defibrillator. If you don't have the manual defibrillator, get the AED and fix it, then you give a shock. While doing that, if the patient does not have a line, get a line and get the medication running. And if it is fibrillation, the first medication when you start your high quality CPR and defibrillation, the first medication is your epinephrine. Give your epinephrine, then on the third shock, you can bring in amiodarone. Do you understand my point? So the amiodarone, you usually give it 150 milligram bolus. Then if there is a need, you can repeat another 150 milligram again. Then after that, you can now titrate the rest on IV fluid over 24 hours. But the key things that you should remember is this. If the etiology is ischemic, then you also remember that you have to bring in your lidocaine. And lidocaine is present everywhere. Even in the primary healthcare center, there is lidocaine. The only thing is that lidocaine usually comes in two forms. The two forms are what? 1% lidocaine and 2% lidocaine. Then there is one that comes with adrenaline. That is not the one we are talking about. We are talking about the plain lidocaine that either come in 1% or 2%. So the one that, if you are using the 1 or 2%, you can always check them up. But you don't need to keep all these things in your memory. Just check them up. If you are using the 1 or 1%, what you will do is that 1 mil of that 1% is equal to how many milligram? Yep. 1 mil of that is equal to 10 milligram. While the one of 2%, 1 mil is equals to 20 milligram. Am I right, Dr. Sekusa? Very good. So this is how you mix it up. So when you do that, you dilute it. If you give it by weight, you can give it, let's say, if you estimate, because as at the point of emergency, that is not where you will now start looking for the weight of the patient. If I look at you now, I can estimate your weight. I am either +5 or 10, +5 correct or -5 correct. That is the way you estimate a weight in emergency. So if I look at Mana, I can say that maybe her weight is 75, but she said no. Or I can say her weight is 80, 65. No. She's more than 65. 70. So the 75 I said is correct, because when you estimate plus or minus 5 to 10, there is nothing wrong by that. So because you are in emergency, so you don't, okay, time is going now. Okay, 5 minutes, no problem. Thank you very much. So the key thing is that once you estimate, Then you give it 0.5 to 1 milligram per kg. That is how you give lidocaine. So it depends on which one you have. So you consume, like this patient, the first patient I presented, do you know that we started with amiodarone, it fails. Then we went to MASOC, magnesium sulfate, because the lady keep having ventricular fibrillation. Once you shock like this, because as she come, we switch off the device, put her on a monitor, then slap a manual defibrillator on the lady. So, and there it reads out. I just taught a young MO on how to do it. So once you just see the reading coming up, press this and you move. And the good thing is that when you are shocking ventricular fibrillation, you don't need to synchronize. If you're also shocking pulseless ventricular tachycardia or to side the pointers, you don't need to synchronize. These two readings, you just take the juice, 200, and you deliver the juice, and it gives you result. So we went to MASOC, and at MASOC we gave it multiple doses. For those of you who deliver women and that goes into eclampsia and severe preeclampsia, I think you do use MASOC. That MASOC, we gave it according to whatever you call it, pressure regimen. We gave it higher. No way. We have to now add lidocaine to it. Lidocaine came into it, yet we are still having this shock. Then I called Dr. Seko, we now talk. He said, why not? Why shouldn't I add propanol? We just added little dose of propanol with the other medication, not that we are giving one and exempting the other. And the patient responded. So this is how you do it in most time. But the question is that if a patient have this degree of arrhythmia, you should be able to look out for the etiology. So the first etiology is to do the EUC to be sure that the electrolytes are no problem. Then the next thing is what? You should also look at the coronary artery to be sure that there is no unstable angina or no stenosis in any of the coronary artery. I've talked about all this. So if there is any identifiable cause, identify it. Then the other thing is that after you have saved the patient, if the patient has no ICD, it is better you put the patient on ICD. I think you will have this slide. If you have any questions, you can ask. I think I've talked about the meat of the matter. Do you have any question? So beta blockers, I've talked about beta blockers, I've talked about propranolol, then I've talked about metoprolol, amiodarone, the magnesium sulfate if the need arise. Then there is also the use of lidocaine, especially in patients you are suspecting ischemia. Then MASOC, I've talked about it. Then there is also the use of denervation of the sympathetic nerve. Is also there. Intubation and anesthesia. Intubation is very important because when you give all this medication and the patient is not responding, you get the anesthetist and intubate the patient, and that may allay anxiety to get the patient better. Thank you very much.